recording this session?
Oh, yeah.
Okay,
Yep.
so it sounds like that's going. All right,
Not a
thanks a lot.
problem. And also, if you guys want my slides, I can send those off. I feel like there's a few people here who have actually probably already heard this talk. It was a few years ago. I saw Heather was on there, so I know Heather has heard this talk before. And I think it was kind of through the grapevine, you know, somebody approached one person who approached the next person who then said, it got to me and I said, sure, I'll do a talk on oncologic emergencies. I'm going to say it's not the most exciting thing that I talk about, but obviously for you guys working in urgent care, this is your bread and butter. So I always find it kind of a hard topic to make interesting. There's somebody who's got their mic on and it keeps making noise. If you could all mute, that would be awesome. Sorry, there was just some feedback. So I will, you know, I always struggle to know how to present this. Do I just, you know, list things? Do I give cases? You know, and I want to be all encompassing, but obviously I can't tell you about every single oncologic emergency that could happen. So I should probably start. I have no conflicts of interest to disclose at this time. So basically an oncologic emergency is defined as any acute incident, whether it's direct. Oh, hello?
Yeah.
Oh, someone saying something?
Oh, you're
We're okay? Okay, sorry. An oncologic emergency is defined as any acute incident, whether it's directly or indirectly related to the patient's cancer or their treatment, which may result in permanent morbidity and or death. So by this definition, if you have cancer and anything that's an emergency is an oncologic emergency by this definition. But we tend to kind of think of it being a bit more specific than that when we're talking about oncologic emergencies. And I remember when I went through training, basically we would say there were two types of oncologic emergencies. There were structural and there was metabolic. And that's overly simplified. And I've kind of come up with more of a categorization of various oncologic emergencies that range from, you know, the metabolic and hematologic, cardiovascular, neurologic, infectious, and then this big category we call treatment-specific toxicities. And I see people are chatting, but I can't look at the chat. There we go. Heather said hi. What I'm going to do is just kind of walk us through the different types of oncologic emergencies. I'm going to have a couple of cases that I'm going to use to illustrate. I'm going to be pretty quick going over the first categories because I want to spend more time on the treatment-specific toxicities, because especially with these new drugs that we're using, and a lot of times you guys haven't got a clue what they are or what they're doing because, you know, they've got these weird names. And even when I'm covering a colleague who, you know, I treat lung cancer and endocrine malignancies, and I have, you know, a colleague who has breast cancer. I'm being called about their breast cancer patient and they're on a drug I've never heard of. So, you know, there's a lot of new things happening. I think spending more time on these treatment-specific toxicities, I think, is of help. So, oh, it's just froze on me. So probably the most important thing that I can do for you today is give you resources. So we do have Alberta cancer guidelines for oncologic emergencies. I actually looked up these guidelines today to see where they're at. And from what I can see, they've been updated as of February of 2022, which is good because the last time they'd updated them was like 2018. Another really good resource is the European Society of Medical Oncology guidelines for immunotherapy toxicity. This is for those patients who are on immunotherapy drugs like nivolumab, ipilimumab, atezolizumab, durvalumab, and they can present with some very strange toxicities that you would never think about. And the European Society of Medical Oncology have come up with these amazing guidelines that have these beautiful algorithms that tell you, you know, if somebody's having, you know, 10 bowel movements a day, that's a grade 3 colitis, and these are the pathways that you should take. These are the investigations and that sort of thing. The other really helpful resource is the BC Cancer Agency Drug Manual. They keep that very up to date. And what's really helpful is, again, you might see somebody who's on a medication you've never heard of before. And if you look at just like the product monograph, you know, every single drug will have diarrhea down as a side effect, for example. But when you go to the BC Cancer Agency's drug manual, they actually have them in kind of common, uncommon, rare, so that, you know, you're more or less likely to say, oh yeah, this makes sense. This is probably related to the drug they're on, or this is a toxicity listed like in that less than 1% of patients. Maybe I need to be thinking of something else. Maybe it's not the drug itself. I have to say the ESMA guidelines and the BC drug manual I use routinely. You know, there's, you know, probably hardly a time on call where I'm not looking something up. And I'm an oncologist. So I always try and put the ESMA guidelines on the bottom of my progress notes on patients who are on immunotherapy. That's my practice, but not all my colleagues do that. But these are really, really helpful resources. So if you get anything out of this, it's these resources. So I'm going to start with a case. And I've kind of made this case up to fit what I'm talking about. But it's just, again, to illustrate some of the things that we have to think about when dealing with oncologic patients. So this is a 67-year-old woman who came in by Uber because she'd been talking to her daughter on the phone, who lives 3 hours away, and the daughter had said she wasn't quite herself. Patient arrives. She's in no apparent distress. She's oriented to person and place, but not to time. There's no altered level of consciousness. And the only thing she's complaining about is some low back pain since she was playing golf about 3 weeks prior. Her family doctor had prescribed some Percocets, which were helping with this pain. And like I said, very kind of vague sort of symptoms that, you know, if her daughter hadn't told her to go to urgent care, she wouldn't have presented. So she gets some blood work done, and that comes back showing that she's mildly hyponatremic. Her creatinine is elevated from her baseline. She doesn't normally have kidney issues. And she's hypercalcemic. She's got a calcium of 3.2 and an albumin of 29. Now, this lady isn't the most forthcoming in terms of her history. So someone has a look at Netcare, and they note that she had a prior diagnosis of a stage 1 ER/PR positive HER2 negative breast cancer, which was resected with curative intent 5 years previously. She had that followed with some adjuvant radiation and then hormonal therapy for 2 years, which she stopped because of side effects. She's being followed by a nurse practitioner in the breast follow-up clinic, with her last visit 3 months prior. No recent imaging, and blood work done 4 months prior was normal. So, metabolic oncologic emergencies. So this brings us to hypercalcemia malignancy. Now, at this moment with Ms. Jones, we don't actually have confirmation that she has malignancy. She was treated with curative intent. And, you know, she's 5 years out, but she did have breast cancer. She did have enough risk factors that she was given adjuvant treatments. And, you know, when I think of, you know, hypercalcemia in a patient who's had a prior breast cancer, the thought is, you know, is this bone recurrence? That would be a very common scenario that patients would present with bone-only recurrence. So at this moment, you know, I'd be presuming that this could be a hypercalcemia malignancy, and that's defined by a corrected calcium of more than 2.6. About a third of patients with cancer will at some point have hypercalcemia. We see it most commonly in our breast, lung, and kidney patients, but of course, patients with myeloma and some of our leukemias can also have it. These patients often present with just confusion or not being quite themselves. Often this hypercalcemia malignancy is more gradual in onset, and they may not necessarily, it might be the symptom that they present with where we diagnose their recurrence. And for these patients, management is IV fluids and if renal function allows, a bisphosphonate. So another metabolic oncologic emergency would be the syndrome of inappropriate ADH secretion. So you may have noted that she was hyponatremic. And not all patients who are hyponatremic have SIADH. And I'll just let you know, in her case, she was a bit dry and with some IV fluids, the sodium recovered. But in those patients who present with hyponatremia due to SIADH, it's due to this inappropriate production of antidiuretic hormone, usually due to the ectopic production by the tumor itself. So small cell lung cancer is the most common malignancy that will present with an SIADH. I have many patients in my lung practice where their presenting symptom was confusion. They were noted to be hyponatremic, and then they had a chest X-ray which showed a tumor in their chest. Some of our chemotherapy and other medications can cause SIADH. And the other time that we see it is when there's intracranial pathology, regardless of the type of primary. So just having metastases in the brain can cause SIADH. So if I have a stage 4 adeno of the lung with, who's on treatment, then all of a sudden they start to develop hyponatremia and they're investigated and they're noted to have SIADH, I'm going to scan their head because most likely they've got brain mets now. Most patients with hyponatremia will present with confusion. They can have altered level of consciousness. Sometimes they have headaches. They can be in a profound delirium and even can present with seizures. SIADH hyponatremia tends to be more gradual in onset. So it's almost like the body's sodium thermostat resets. And so they can come in with really quite, low sodiums, 113, 115, and only have confusion as their symptom. So coma and respiratory arrest are pretty uncommon in this patient population with SIADH. And the management of SIADH is really treat the underlying cause. So in my small cell patients, starting them on chemo will basically result in their SIADH improving. However, fluid restriction is also kind of what we do initially with these patients. Many patients with SIADH have mild symptoms and just this fluid restriction will do the trick. But in some cases where they are more profoundly symptomatic, they have more severe symptoms of hyponatremia, or they've been symptomatic for a longer period of time, we may need to admit and give them hypertonic saline and inpatient monitoring. We don't want to correct this sodium too quickly because of this complication of osmotic demyelination syndrome. I've never seen it, thank goodness. And these patients, because they've probably been hyponatremic for a longer period of time, they are more sensitive to this because they've had low sodium for so long that they'll be more sensitive to the osmotic demyelination syndrome versus somebody who's more acutely hyponatremic. We can often correct them a little bit faster. But once again, if in doubt, this is a patient that would need to be admitted and monitored to correct their hyponatremia. And then the other metabolic it was a long afternoon. The other metabolic oncologic emergency would be tumor lysis syndrome. And I'd say this would be something that would not present to urgent care. This is usually seen in patients who are admitted to hospital and are actively getting chemotherapy or radiation for a high burden, rapidly proliferative malignancy. And it's most commonly seen in our hematologic malignancies. I have, over the last 20 years, had probably 3 or 4 of my small cell lung cancer patients develop mild tumor lysis. And basically, tumor lysis is a result of these very chemo radiation sensitive tumors just having like rapid response to treatment, and they get this dumping of their intracellular components into the bloodstream, and it's characterized by major electrolyte disturbances. So hyperuricemia, hyperkalemia, hyperphosphatemia, and hypocalcemia. And it can lead to renal failure, seizures, arrhythmias, and death if not treated in a timely manner. The good thing about tumor lysis, though, is that we're aware of which malignancies we tend to see tumor lysis in. And those patients, again, are usually treated as an inpatient and get aggressive IV fluids. Sometimes they'll follow the uric acid and even give them allopurinol prophylactically. And the key to this is the early recognition and correction of these metabolic abnormalities. And as long as they can pee, just the use of IV hydration and diuresis should be able to get over this. But again, this is not something that would be commonly seen in urgent care or emergency care, because these patients typically are in hospital at the time of this happening. So that brings us to some hematologic oncologic emergencies. I'm just going to really quickly go through these guys. I mean, I bet, you know, the big one would be malignant bleeding. Regardless, sorry. Okay, so Gar said, is significant hypercalcemia an indication for admission? Or if the patient is not confused and clinically well, can calcium be corrected in urgent care? If yes, what are reasonable discharge criteria? Well, that's a hard one to answer. I would say it's very much based on how well the patient is doing. You know, if they're noted to be high, I mean, I manage most of my hypercalcemias as an outpatient. I had a patient a couple weeks ago, came to clinic, was hypercalcemic. We got some IV fluids. I arranged for a Zometa to be given the next day. Patient never needed to be admitted. I mean, obviously, if they're very hypercalcemic, you know, you're getting up to the, you know, 3.5s or higher. Those patients, we'd probably want to bring them into hospital. But the, you know, milder hypercalcemias with less symptoms, it's not unreasonable to try and manage them as an outpatient. Our biggest issue is access to the bisphosphonate. It's not currently approved as in the cancer formulary, so it can't be given in the cancer center or any of our community cancer clinics. So we actually have to go through day medicine at Foothills, where we have admitting privileges to get it, not only given, but also paid for. So one of the reasons we may admit is just purely being able to give the bisphosphonate in a timely manner, because we just can't we can't give it to patients in the cancer center. It's kind of silly, you know, it's a management of a cancer complication, but right now the cancer formulary just doesn't cover the cost or the administration of our bisphosphonates. Is that okay, Garth? We're good? Okay. So hematologic complications, bleeding, you guys all know about bleeding and what to do, depending on where it's coming from, you know, hemoptysis, hematemesis, hematuria, vaginal bleeding. And then other hematologic complications, again, things that we don't see very often. I don't see a hyperviscosity syndrome. That's typically seen in the hematologic malignancies. And again, very rare. Basically, it's due to increased protein content or large molecular sizes of the cells are in excess. So I've seen a patient with CLL, for example, with a lymphocyte count in the thousands, who actually developed hyperviscosity syndrome when I was a resident. And these patients present with kind of bleeding and clotting all at the same time. And then we have our DIC. DIC in our solid malignancies is typically a terminal event. So we normally will only see DIC in patients who have progressive disease, no longer amenable to treatment, and it is kind of a terminal event. In some of our hematologic malignancies, people might present with some DIC, and treating the underlying cause will resolve the DIC. But in our solid cancers, that's very uncommon. But again, it's not something we see very often. Okay. And then cardiovascular oncologic emergencies. Superior vena cava syndrome. I'm going to say that most of the time, superior vena cava syndrome is not an emergency. It's always listed as one of our oncologic emergencies. It's very uncommon that we actually have to intervene in an emergent way. So patients they typically are patients who have disease involving the mediastinum. I see small cell lung cancer, for example, presenting with superior vena cava syndrome. And patients will describe dyspnea, a sense of pressure or fullness. Inspiratory stridor is very rare and would definitely be an indication for more emergent management of SVC obstruction. They'll describe facial fullness. Often they'll say, I'll wake in the morning, my face is swollen. As the day goes, my face is less swollen. They'll notice jugular venous distension, collaterals on their chest wall. They'll have headaches. And the other thing patients will describe is they say it's like they've got earmuffs over their ears. They'll give this sensation like things are muffled. And really, it's only an emergency if we're worried about airway compromise or they have such severe vascular congestion that we need to intervene quickly. How do we diagnose this? Well, a chest X-ray may show an anterior mediastinal mass, but typically this is best seen on a CT scan. So in patients where SVC obstruction is suspected, it is still important to get imaging done promptly, and those patients would probably need to be sent to one of the emergency departments to have imaging if that was suspected in one of your urgent care settings. For SVC management, the type of cancer really makes a difference. Sorry, my computer's at home in here, the font sometimes gets a bit messed up. So here it says histologic suspicion or confirmation is key. In patients where we don't have a diagnosis and they are unstable, we might have to put in an SVC stent, but only if their superior vena cava is, there's no clot. So in some of these patients, they'll actually develop thrombus with the SVC obstruction, and then they can't put that stent in because all you're going to do is push that clot further into the lungs, and these patients will develop things like saddle embolisms. So SVC stenting, the SVC has to not have a clot in it. In patients who have a diagnosis of a chemosensitive tumor, such as small cell or lymphoma, management is with high-dose steroids and initiation of chemotherapy ASAP. So we don't necessarily always treat with radiation. In tumors that aren't as chemosensitive, though, radiation is typically the way that we manage SVC obstructions in conjunction with steroids. And with patients who have chemo or radiation sensitive tumors, 70 to 90% of patients will have a complete response, meaning their SVC obstruction will resolve. Other tumors, it's about a 50% chance that we're going to get their SVC obstruction cleared. But even in those 50% of patients, often there'll be improvements in their SVC symptoms. And with their collaterals, often over time, things will improve even if the SVC continues to be obstructed. And as I said, not many times these are more urgent rather than emergent conditions, because those collateral, unless it's a really fast growing tumor like a small cell, usually that tumor has been there for a while and that SVC obstruction has been coming on gradually. And we do have the ability to get a tissue diagnosis and figure out what's the best first treatment, whether that be radiation or chemotherapy. And the other one that I think often I get a lot of questions about, is pericardial tamponade. A lot of patients, at least with lung malignancies, will have a pericardial effusion. It's very common to see pericardial effusions in our patients, especially when they have pleural involvement and pleural effusions. Getting pericardial effusions are very common. The vast majority of those patients never develop a pericardial tamponade. And so I get a lot of, I do get a lot of calls from family physicians saying, well, the CT showed a pericardial effusion, should we be draining it? And I'm like, no, we'll just treat their cancer. When we do drain it, obviously, is when they do present with a tamponade. And that's, because that can lead to hemodynamic compromise. You guys all know how to diagnose a cardiac tamponade. The key with this, though, is patients need to be seen by cardiology. They're the ones that will do the echocardiogram. They will determine if there's enough compromised that draining the fluid will be of benefit, and they are the actual ones who will do the pericardiocentesis. So in patients where pericardial tamponade is suspected, it's really important to get cardiology involved quickly. We're doing okay? I have a little tiny screen off to the side where I can see a couple of people. Okay, so now we're going to talk about neurological oncological emergencies. So we're going to come back to Miss Jones. So she's a lady who presented with hypercalcemia, and she also had this 3-week history of back pain. And in this lady, given her prior history of breast cancer, new hypercalcemia, and recent progressive low back pain, you know, I'm going to think, does this lady have bone mets? And is there any reason that she may have a cord compression or cauda-equina syndrome where we have to be doing something more quickly? So where she's being seen in urgent care, they do a physical exam, and they note that she has she's hyperreflexic in her lower extremities with the upgoing plantars bilaterally. She's still able to walk. She doesn't really complain of any numbness in her legs, but you know, when they do a post-void, when do you as an oncologist involve cardiology for assessment if they have symptoms of a pericardial tamponade? I don't normally get cardiology involved with pericardial effusions unless they're having symptoms that make me think that this is going to be a pericardial tamponade. When I try and get them involved, they usually aren't very happy with me because they're like, is there symptoms of tamponade? Is there a pulsus paradoxus? And if I say no, they're like, well, we don't need to see. So that's the only time that I get cardiology involved, is if there's clinical suspicion of a pericardial tamponade. I'm just answering the questions in the chat. So back to Miss Jones. They do a post-void catheterization, and she does have some urinary retention, even though, again, she can void on her own. This is concerning. But given this history, the hypercalcemia, you know, I would be highly suspicious that she has bone mets in her back. And again, I'd be worried that she has an impending cord compression, even though she's still walking. So malignant spinal cord compressions, about 10% of patients with advanced cancer will have evidence of spinal cord compression. It's most commonly seen in lung, prostate, and breast. It's very rare for this to occur from a primary spinal cord tumor, so it's usually going to be from metastases. And these patients will present with escalating back pain and or radicular back pain. They can have weakness, sensory deficits, and loss of bowel and bladder control. And the gold standard for diagnosis would be an MRI with gadolinium. In patients where you suspect spinal cord compression, you're never wrong to start them on steroids. So I looked at the literature to see what is the recommended dose of steroids, and there is no randomized control trials telling us what dose of steroids we should use. When I looked at various, you know, the neurosurgery associations, supportive care, like palliative care, most say start with a 10 milligram IV loading dose, and you follow that by a 16 milligram dose daily, either given 8 BID or 4 QID. The bioavailability of dexamethasone, which is the steroid we typically use because it has better penetration into the CNS and into the spinal space. Dexamethasone has a really high bioavailability. So even in patients where you might not have access to an IV or the IV medication, giving it orally is still very effective. And for spinal cord compression, it's really important to get the input of both our radiation oncologist and neurosurgeons. So medical oncology, there's really never a chemotherapy that's going to manage an acute spinal cord compression. It's going to have to be something more focused, such as radiation or surgery. The best case scenario is where surgical decompression can be done. We know that we have our best outcomes in patients who can have surgical decompression as the management of their cord compression. Now, the neurosurgeons understandably want to only operate on people who have limited disease in their vertebra. So if they have multiple levels of cord compression, it makes it difficult because you can't really decompress like 4 or 5 levels at once. The patient should have a reasonable life expectancy, meaning that they will benefit from having gone through a surgery and have a recovery time after surgery. The performance status should be good enough, and their other sites of disease should be limited or well controlled, or has the potential of being well controlled. And there was actually a trial that was done called the PathCell trial, where patients were randomized to surgery followed by radiation versus radiation alone for treating cord compression. And we saw that the ability to return to full ambulation was much superior in patients who had surgery with radiation versus radiation alone. However, radiation still is a very effective treatment. In the vast majority of patients, if we use radiation, we'll have a reduction in the pain associated with the cord compression. So 70 to 90% of patients will have a reduction in their pain with radiation. And in patients who were walking prior to getting the radiation, 80 to 90% will have complete recovery of their neurological function. If, however, the patient is not able to walk, they're hemiparetic prior to getting the radiation treatment, the rates of recovery are only about 30%. So obviously time is an issue. And sometimes getting that steroid started is enough to keep them still walking so that, again, they're more likely to have a greater benefit. This type of radiation is actually considered a very simple radiation. You don't really need to know the tissue, the actual diagnosis. So in somebody who is suspected to have metastatic disease, but we don't have the pathology back, the radiation oncologist can still plan this radiation and give it. And unlike other radiation, so, if a patient is getting radiation to a tumor in their lower lung, where the lung moves a lot, that radiation planning is very complicated to minimize, collateral damage to healthy tissue. While radiation of the spine is really a much simpler planned radiation. And I'm not a radiation doctor, but they tell me it's very simple. So getting them involved. So if you have a patient who's presenting to you, you're suspecting an early cord compression, or they have very convincing signs of a cord compression, the recommendation is typically neurosurgery first, because we know they have the best outcomes. And if for some reason neurosurgery says, no, this is not a person we'd operate on, the next person to talk to would be the radiation oncologist. And again, medical oncology really has no role to play in managing acute spinal cord compression. So if we come back to Ms. Jones, given her clinical presentation, Rapid is contacted and neurosurgery speaks to the physician in the urgent care facility. Patient is transferred to Foothills, where they have an MRI with gadolinium, which does confirm an acute cord compression due to new bone metastases. CT shows no visceral disease, and a bone scan shows only a few other early bone mets. So the patient actually undergoes surgical decompression followed by radiation, and the pain resolves and she is able to ambulate and now is able to go ahead with getting systemic treatment for her recurrent metastatic breast cancer. Okay, so another oncologic emergency that falls under the neurological category would be cerebral edema. And the most common reason for cerebral edema would be the presence of intracranial tumors, such as brain metastases. It's uncommon, although not impossible, that somebody can have a primary brain tumor presenting with symptoms of cerebral edema, but far more commonly, it's going to be brain metastases. And my lung cancer is number one, with breast, renal cell, and melanoma being really high up there. So patients presenting with cerebral edema can present with headaches, seizures, nausea and vomiting, and of course, focal neurological symptoms depending on the location of their lesions. CT scans can be helpful in finding these tumors and looking for associated edema and mass effect, but MRI of the brain is far more sensitive for smaller lesions and equivocal lesions. It can also help us distinguish between malignant and non-malignant etiologies. And now is really important for making treatment decisions because, 10 years ago, if you had brain metastases, there was one option, which was whole brain radiation. Very simple radiation to give. Outcomes weren't great, but there's been a lot of work that's happened in brain metastases, and we are treating them much more aggressively because evidence supports that. Okay, should we be referring med-onc patients who we suspect with spinal mets but don't have clinical clot? Spinal mets still should go to radiation oncology because it's still going to be radiation that we're going to do first. If you don't, you could talk to spine. Again, if I've got somebody that I'm worried may not yet have a cord compression or a caudiclina, but I'm worried might, I still want that to be managed, whether it be surgical or with radiation. So, if there's only one person you needed to call, radiation oncology would be your best bet because they can always get neurosurgery involved. Med-onc is not the best people. We're not the best when it comes to spinal mets.
Understood. Okay. So even the ones that aren't in dire straits, it's still very reasonable to speak with radiation oncology that day.
Absolutely, because they can get them in really quick. We have mechanisms that we call fast track for these sorts of scenarios that, the thing about the radiation oncologist is they'll often see people, treat them very quickly, and then they then will have the med-onc take over the care and then manage the visceral disease and do the systemic treatments. So yeah, the radiation oncologist is your best bet. And they're always oncologists like we are. So.
Great, thank you.
No worries. So cerebral edema. Oh, I just saw another thing. Okay, so Hodgkin's in the US. Okay, again, I would talk to hematology on that because the medical oncologists here don't treat Hodgkin's. That's treated by the hematologist. You can always have, I'm going to say this is not a scenario that I ever see because it's not a malignancy that I deal with. But again, you can always talk to the hematologist. But the radiation oncologists who deal with the lymphomas and the hematological malignancies also have a really clear understanding of how best to manage. And so if in that scenario, they routinely give chemo and radiotherapy for cord compression for Hodgkin's, they would already know that because we're all so subspecialized here, and actually in most places more and more we're becoming so a radiation oncologist or on call will be a general one, but they'll often refer the patient to be seen specifically by a radiation oncologist who deals with that tumor site. Okay, so cerebral edema, MRI is definitely most helpful. I know CTs are always quicker and easier to get. I'm going to tell you, if I get a CT scan and I see a brain met, I have to get an MRI. So in my patients, I usually just jump to an MRI right away if I'm suspicious of it. And that's because of the fact that we have this, in Alberta, we have a multidisciplinary team called ARC, or the Alberta Radiosurgery Center. And there are neuroradiologists, radiation oncologists, and neurosurgeons who are part of that team. And they triage all referrals of new brain metastases through their clinic. So once a week they meet and preferably look at MRIs, and they make decisions about how is the best way to manage this particular patient's brain metastases. So that's why an MRI is is the best test when it comes not only to make, to determining where they have the disease, but for this Alberta Radiosurgery Center to make the ultimate decision about what's the best treatment. However, in the meantime, again, just like the cord, initiating steroids can very rapidly improve symptoms. And a lot of patients will don't even need to be admitted to hospital. They get started on dexamethasone, and within a few hours, their symptoms of cerebral edema improve, and we're able to manage them as an outpatient. And we don't routinely give anticonvulsants prophylactically. There's no evidence to say that it prevents people from having seizures. And obviously, medications like Dilantin have potential toxicities. I've seen 5 cases of toxic TEMS, toxic epidermal necrolysis, and 4 of them were on prophylactic Dilantin for brain mets. So, they didn't need to be on it. And I think Evan has his hand raised, and that's the only hand I can see.
Yeah, thanks. I was just wondering about the imaging. At Chumir, we do have CT on site, and so it's very accessible. If we have somebody with a high-risk known primary or history of, with a new headache or maybe a first-time seizure, would you suggest then we just talk to a radiologist for an urgent MRI and just bypass the CT with contrast or whatever we have access to?
I think in that acute setting, if they're presenting to you, it's still reasonable, because, that might, you might find that they've had a bleed, which
Sure.
might make it that you should be talking to neurosurgery, because bleeding brain mets, often we do need to intervene with neurosurgical interventions, because that's the only way we could get on top of things. I hadn't quite got to that yet, but so, it's one of those things, and I guess it's this talk is kind of designed for different groups of people, but for you guys, if they're presenting to you and you guys have access to a CT scan and you're going to get a quick answer, I don't think it's unreasonable. We can often actually get the MRI faster if we have a CT that already shows a brain met.
Right.
I find that when I order MRIs and they haven't had previous brain imaging, it may take longer than if I'm like, okay, we've got a CT with brain mets, and now I'm ordering the MRI because I need it for ARC. And it seems like it gets protocoled very quickly. And that's my experience with that.
Thanks.
Okay, no worries. So it's so funny how things have changed. Like 20 years ago, nearly every patient who presented with symptoms of cerebral edema was admitted. They were given IV steroids, and we kept them in hospital until they finished their radiation. That is really uncommon now. The vast majority of these patients, I'll get a call from radiology on somebody that I'm doing staging CT, and they've got brain mets, and I call the patient, they've got headaches and throwing up. I'm like, okay, I'm going to call in a script for some Dex, and if you're not better by tomorrow, let me know. And I call the next day and they're fine, and we're able to then do everything as an outpatient. It's very different, but Dex has such high bioavailability that you don't always need to give it IV. I would say it's never wrong to give somebody a dose of steroids, especially if you're very suspicious. I think that was David. Yeah, I'm always just thinking about the patient. If this person has metastatic disease, they're likely don't have curable disease, which means they're being treated with palliative intent. Palliative means to make people feel better and live longer feeling better. Starting steroids will do both. It will actually make people feel better and prevent the progression of their symptoms, so that they can then get their treatment, which will then make them live longer. So yes, I would say steroids is a very reasonable thing to start. Again, you can always call us and ask, but the reality is I know the hematologists sometimes will say that if you suspect something like lymphoma, they're not always keen on steroids. I think it's becoming less of an issue with them using all the molecular profiling and stuff for making their diagnoses, but I can't speak for hematology. Okay, so how do we treat cerebral edema? Well, surgical resection. So sometimes we have to do that on a more urgent basis because they require more urgent decompression. So patients who have intracranial bleed or significant mass effect, sometimes they don't have the time that it would take to plan and give the radiation, they would need to go to surgery right away. Sometimes the location of the lesion, so cerebellar mets are often resected because the posterior fossa is such a tight spot, and cerebellar lesions tend to bleed more. And then we also use surgical resection if patients have solitary brain mets or minimal brain metastases that are easily accessible. And surgical resection is typically followed by radiation. So we don't normally just resect. Radiation is always part of the picture when it comes to brain metastases. The next kind of best thing, because if we can surgically resect and follow that by some radiation, we know the outcomes are the best. These patients will do the best. I have a lady in my practice who was diagnosed with stage 4 adenocarcinoma of the lung in 2015, presenting with a solitary brain met. She actually has no use of her left arm right now because of the brain met. She had that resected, followed by stereotactic, and she had lung primary with liver mets. I've given her chemo. She got first-line chemo. She actually had a complete response to chemo. She's had no treatment since May of 2018, and she's had no recurrence of her cancer. Now, that is extreme, but, 10 years ago, this lady wouldn't have had resection. She would have only had whole brain radiation, and she would have died within 6 to 9 months from her brain mets. So we've seen huge changes, not only in the survival, but even the type, the quality of that survival in patients who are able to undergo surgical resection. The next best thing we have is stereotactic radiosurgery. So that's basically a very high dose, high precision type of radiation. It can be given in a single fraction. So patients who are willing to have these halos put on so that they don't move a bit can get a single dose of radiation, a very focused one. It's almost like using the radiation like a knife. Other patients who don't want that, they might have to give the radiation over a few days because they have to alter the dosing a little bit because you can't 100% be in exactly the same place unless you're in one of those halos. And so stereotactic radiosurgery is something that we use for patients with limited brain mets. Now, the definition of limited has changed. At first, 6-7 years ago, less than 5 brain mets would be considered limited. And then some studies were done, and it was like, well, actually, we can do stereotactic radiosurgery if they have 10 or less brain mets. And now up to 15 brain metastases are being treated with stereotactic. And we know the outcomes are better. Not only do they respond better, but patients do better. They have less cognitive issues that you might get with the whole brain radiation. You can retreat effectively. And so these patients kind of get spot treated for these brain mets, and again, are living a lot longer and a lot better for that period of time because of stereotactic radiosurgery. And then there are, of course, the patients where both resection and stereotactic are not options. Usually those are patients who have innumerable brain mets where there's too many to be able to focus on, or they have leptomeningeal disease. And this is a more diffuse radiation, usually given over 5 to 10 treatments. Outcomes on whole brain radiation is much poorer. Survival benefits are lower. So this is why we always want to try and give patients the best potential options for, responding and the duration of that response. Okay, how are we doing for time? Infectious oncologic emergencies. I'm just going to quickly go through this because I think most of you guys know about febrile neutropenia. So febrile neutropenia is basically defined as having a fever and being neutropenic. So if somebody comes in with a fever and they're not neutropenic, it's not febrile neutropenia. And if somebody is noted to be neutropenic but doesn't have a fever, that is not febrile neutropenia. It really is both. Again, 20 years ago when I started in practice, every one of these patients would have been admitted. They would have been started on IV Piptazo, culture, chest x-ray. When their counts had come up and they'd been afebrile for 48 hours, we would step them down to an oral antibiotic, follow them for a couple more days, and then send them home. Nowadays, we very rarely admit our febrile neutropenics. And that's because there's been a lot of work that has gone into seeing whether or not these patients could be managed as an outpatient. And so they've stratified it into low risk and high risk patients. So patients who are on chemotherapy drugs that likely are only going to have a neutropenia lasting 7 days or less, they're clinically stable and they have minimal comorbidities, they can potentially be treated as an outpatient. And those patients typically, they have to be able to take an oral antibiotic. We usually say it'd be good if they have somebody at home with them. They're willing to seek medical attention if things get worse, and they feel comfortable with that decision. And I'd say 70% of our solid tumor patients fall into that low risk category and never need to be admitted with febrile neutropenia. Typically, we use ciprofloxacin and amoxiclav. If patients are being seen in a clinic, sometimes, just being watched for a few hours to make sure that they don't, become unstable before sending them home. And I find that most of the time when patients go to our emergency or urgent care clinics, they've already been there for a while before they're being seen, and then they get started. So it's not uncommon that on call I'll get a page and they'll be like, Mrs. So-and-so's in, she's adjuvant breast, she has a temp of this, her neutrophil is this, she's well, we've cultured her up, and can we send her home? And we usually say yes. When do we admit? If patients can't swallow tablets, we're concerned about them. So, my homeless patient who's living at the drop-in center, probably wouldn't send him because I wouldn't be necessarily confident that he would have a good support system there. If this patient has had previous febrile neutropenic episodes where they were found to be bacteremic, and those patients will often admit because we're worried that they'll have the same bacteremia and will require IV antibiotics. And then obviously, if things change, they become more unstable, they go home, they continue to have fevers, then we might admit. The high-risk patients are usually those ones who have anticipated low counts of greater than 7 days, are clinically unstable, or have significant comorbidities. A patient with severe COPD already on supplemental oxygen, now febrile neutropenic, would likely be admitted because they could go, become unstable very quickly. And those patients will admit, and we'll give them the IV piptazo most commonly, culture them up, and then step them down to whatever they end up testing positive for, if they do have positive cultures. It's funny, I looked at our inpatients. There's not a single febrile neutropenic admitted under medical oncology today. So again, it used to be all our patients when I first started were DVTs needing IV heparin, our febrile neutropenics, and the brain meds. Like, that's all we had in hospital. It's very different from what we have now. Okay, so the last topic is what I term treatment-related oncologic emergencies. Oh, there's a question. Duration of antibiotics, usually 7 days. Yeah, we usually give 7 days. When I'm on call and I get paged about a patient in, Airdrie urgent care, or they're at the Sheldon Chumir and they're sending them home, we do this with all of our I'll email my colleagues to say, listen, your patient was an emerge, this is what they started. You should, their nurse will call the next day to see if they're okay. But normally we'll give them 7 days worth for outpatient management of febrile neutropenia. Okay. So treatment-related oncologic emergencies. So this is a hard one because, is this always a call you want to get? No. But, obviously, I think, if one of the things that the patient can be, we have a telephone triage that's open 8 to 4. And, it's not uncommon that patients will call and say, I was in emerge last night. They sent me home. They told me to call this morning to let you know. But again, I'm okay with being called about this sort of thing, just to make sure that everybody's in the loop. I'd rather know more than not know enough. But and I think most of us feel the same way. Obviously, we're always grumpy if we're woken up in the middle of the night, but we're on call. It's okay. Now, if I was on call right now, I might be a little bit more grumpy about that. But oh yeah, the math score. I want to tell you, our residents are really good at using the math score because they're much smarter than we are. I'm using the math score when I'm asking the questions. You can use the math score. I can't even remember what it stands for. Something about supportive care, but it can be helpful. I'm going to say after 20 years, I'm using my gut more than anything when I'm being asked the question. But yes, there is the math score you can use for determining whether you can send somebody home. But again, most people we don't end up admitting. Okay, we'll get to this big topic. So there are different ways that we treat cancer. Obviously, there's surgery. Surgery is a big part of our cancer treatment, but we don't typically manage surgical complications or urgent surgical issues. But when it comes to the treatments that we give at the cancer center, we have kind of two broad categories. We have radiation, and then we have systemic treatment. So more and more, we're dropping the word chemotherapy, other than if it's cytotoxic chemotherapy. So the traditional stuff that we think about, the drugs that are cell killing, that do things like damage the DNA or impair the microtubules and doesn't allow cells to divide. So traditional chemotherapy is typically where, we'll see pancytopenia, neutropenia. Radiation, there are some oncologic emergencies that result from radiation treatment. So the one I most commonly see is radiation pneumonitis. So patients can, up to 3 months after having completed radiation to their lung, can present with an acute hypoxia, sometimes associated with fever, and it's actually a radiation pneumonitis. And those patients, although it's rare, patients can actually die from that pneumonitis. And the way we manage that is typically with steroids. Prednisone 50 milligrams daily, and let the radiation oncologist know in order to follow up and then taper down the dose. Targeted therapies. So these are drugs that have been specifically designed for either mutations that are being detected in a person's cancer or common pathways that are disrupted in particular cancers. So for example, well-differentiated neuroendocrine tumors often have issues related to the mTOR pathway, which is signal transduction. And so we have mTOR inhibitor called everolimus we use in the management of neuroendocrine malignancies. Everolimus has, and some of our other targeted therapies, such as our EGFR inhibitors, like afatinib, for example, sunitinib, which is one we use in renal cell. Those drugs rarely can cause something called a non-infectious pneumonitis. A non-infectious pneumonitis is, again, an acute lung injury that usually presents with hypoxia, dyspnea, and sometimes even fever. And the development of non-infectious pneumonitis is fatal in 1/3 of patients. Very, very rare, but if somebody comes in and they're acutely short of breath and hypoxic and they're on one of these drugs, the thought of pneumonitis always comes up. And again, we typically treat those with steroids. Steroids is going to be the answer to everything we're going to talk about next. And so this is why I feel like that link to the BC Cancer Agency drug manual is really, really helpful, because, there might be some weird drug you've never heard of before, lenvatinib, and go, I don't know what lenvatinib is. And lenvatinib can cause malignant hypertension. It's this weird toxicity. People can come in with systolics of 240, where they have to have admission and urgent, IV antihypertensive given. It's a drug we use in hepatocellular cancer, for example. Again, but you wouldn't necessarily think of that if you didn't know. And again, it's very unique to that particular drug. We don't really know why it happens, but we do know it does. Then there's the big category and the big and hot area, which is immunotherapy. And immunotherapy is both something that I'm so happy that has developed, because I have so many patients that are doing well for long periods of time, patients that I would never have been able to treat their disease, and they get immunotherapy. I had a lady today, she's 87, stage 4 squamous cell carcinoma of the lung. She's got dementia, and I could never have given her traditional chemotherapy. She got immunotherapy with a near complete response of her stage 4 lung cancer. And she's a year and a half off treatment. She had it for 2 years and is doing well and still has no disease recurrence. I mean, this would not have been possible. So I love immunotherapy for that. I hate immunotherapy for the immunotherapy toxicities. So basically immunotherapy, there's different drugs, but the drugs basically work the same way. They block the ability of the cancer cells from evading the immune system. In some tumors, like our lung patients, we actually test for the PD-L1, which is the substance that's produced. And if they're PD-L1 high, we know immunotherapy is probably has about a 65% chance of shrinking their cancer versus 30%, which is what we would quote for chemo. Other diseases, other tumors, melanoma, renal cell, what's that? Okay.
Just adding the link. Just adding the link so people can click on it here if they want to.
So the problem with immunotherapy is that 75% have no toxicities. They don't get sick to their stomach. They don't need to take pre or post medications. Patients who've had previous chemo and go to immunotherapy are like, wow, like I like that stuff because I don't get sick. But 25% of patients get immune toxicities, and they can range from something very mild, such as dermatologic things, dry, itchy skin, moderate. They can, I've had a couple of people where they've developed hypothyroidism, and I've had to start them on levothyroxine. You name an autoimmune condition, immunotherapy can cause that to happen. I had a gentleman, about 3 years ago, get 1 dose of immunotherapy, and he presented with generalized weakness and actually had myasthenia gravis as a toxicity and died from myasthenia gravis. And the problem with these immunotherapy toxicities is we cannot predict who will get it, which one they'll get, how bad it'll be. So any patient on immunotherapy, if they come in with anything, we always think, could it be the immunotherapy? So, like I said, I had a gentleman pass away from myasthenia gravis. I've seen Guillain-Barré. I have seen, I had a patient die from colitis, actually. She had such severe immune colitis from immunotherapy. She'd gone through, we could not get on top of it. She developed renal insufficiency and was going to need dialysis, and she opted not to take dialysis and died. So it's great in the vast majority of patients, and even most patients who do get immune toxicities, they're manageable, but there are those weird and wonderfuls that come out of the blue that are potentially life-threatening. In my patients, I see a lot of pneumonitis, and I have had several patients die from immune pneumonitis from the immunotherapy. So, when patients say, give me a list of all the toxicities, really, I'm like, I could give you a textbook when it comes to autoimmune. So this is why I always give the link to the Esma guidelines. And I just tell patients, if something is not feeling right, you give us a call and say, I'm really short of breath. So I had a lady admitted yesterday with pneumonitis. She's one of my small cell patients. She's on durvalumab. She got acutely short of breath over 3 or 4 days. She's now hypoxic. She's got immune pneumonitis. So it's this kind of love-hate relationship that we have with it. So I'm just going to quickly go through. So this is just to kind of show you what the Esma guidelines are great, because you'll see they have these beautiful algorithms. And like I say, we refer to this all the time. So when in doubt, you can always look at this. So I'll just give you just a quick example. So Mr. Smith, patient of a colleague of mine with metastatic melanoma with lung mets, presents to the Strathmore Emerge in February 2016. So this is an old case, but it still illustrates the point. With decreased PO intake, nausea, vomiting, increased shortness of breath, altered LOC, but hemodynamically stable. He has a prior history of hypothyroidism and GERD, and he'd been started on palliative immunotherapy with nivolumab and ipilimumab 3 weeks prior. On labs, he's noted to be have acute kidney injury. He's hyponatremic. He's got an elevated. He's got acidosis. He's got a glucose of 47. His hemoglobin A1C though is 5.9, and he's got a really elevated white count. And basically, he has a diabetic ketoacidosis. And in his case, he has actually an immune-mediated destruction of his pancreatic beta cells. So he's presenting with new onset type 1 diabetes secondary to the immunotherapy. So in his case, he was just managed as a DKA. He was admitted to hospital. He was started on insulin, was discharged home 5 days later, doing well, and actually had a significant positive response to treatment. I'm going to tell you, these patients who get these immunotherapy toxicities, it's usually because it's working so well. So I've had patients get an immune toxicity after their first cycle, and we can't re-challenge them. And 18 months later, their disease is still controlled after 1 dose of the immunotherapy. So often these patients who have these immunotoxicities have had an amazing response to treatment. So this gentleman, we continue with immunotherapy in him because his type 1 diabetes is permanent. This is an irreversible thing. Same thing with my patients who develop hypothyroidism. They actually get like a thyroiditis. So we burn out their thyroid. They're never going to have normal thyroid function. They will always require thyroid replacement. So we'll continue with immunotherapy in those patients because even though obviously the DKA was potentially life-threatening, insulin is the answer. So 6 weeks later, he comes back. He's seen in clinic, but this time now he's having diarrhea. So he's having several loose bowel movements per day, despite taking Imodium 8 times per day. And he's being admitted because now our concern is, has he got an immune-mediated colitis? And again, this is a very common thing. I had 2 patients in clinic this afternoon, both who I'm managing for immune-mediated colitis. So this is an example of the ESMO guidelines. So this is the ESMO guideline for diarrhea. And you can see that they grade it based on how many loose bowel movements. And then they give you suggestions on what to do. So if somebody has, 4 to 6 loose bowel movements, you give them fluids, they take loperamide, you do some baseline lab work, you make sure you rule out infections, and most of those patients, these symptoms will resolve. However, if they persist or get worse or become more than 6 loose bowel movements, then we start them on steroids, usually as an outpatient, it'll be prednisone. We get GI involved. So there's all these beautiful guidelines. And again, I know that you don't need to know, it's more like this person needs to be admitted. They're having 10 loose bowel movements per day. They're on immunotherapy. Based on the ESMO guidelines, this is what I need to do. But we have them for all of them, what to do with elevated, if somebody's AST/ALT is elevated, could they have an immune hepatitis? How do you work them up? So these guidelines are great, and we use them all the time. This man, fortunately though, he comes in, we start him on the IV steroids, his bowel movements, we get GI involved, we send him off for cultures. He actually comes back C. diff positive. And this was 2016. So he was treated with Pioflagel. Obviously, that's not what we would do now. They stopped the steroids, his symptoms resolved, and he went back on his immunotherapy. So not everything is immune mediated, but the thing is, in these patients, we always think it could be. And so this is my love-hate relationship with immunotherapy. So to summarize, Cancer patients may experience a range of potentially life-threatening conditions that require interventions, and the prompt identification and treatment can prolong survival and improve quality of life. And there's my resources again. So I know it's a bit of a dry topic, and I'm sorry for that. I'm happy to share these slides, or I can even just kind of cut and paste these resources if that's more important. I'm just going to stop sharing and bring you over here. And I don't know if that's what you guys were looking for.
Well, I can speak on behalf of my colleagues that most definitely, you know, when we see cancer patients, it's they are not a high frequent urgent care patient, but we are seeing them with increasing frequency. And they are certainly not like our average patients, certainly not the Sheldon Chumir Urgent Care Center. And every time they come in and are looking sick and they're on some medications that we're not familiar with, it's always nice to know that there's a friendly voice on the other end of the phone that we can ask questions of Cindy. And I think it is actually very important for us to sort of refresh our memory with respect to sort of common oncological emergencies like the ones you've presented tonight, because as you say, these people can walk into any emergency department, any urgent care center, and we're starting to see more and more of them. So I appreciate the refresher, and I certainly appreciate the resources that you've provided with respect to immunotherapy and the cancer guidelines. I don't see any other questions in the chat box right now, but of course I'm going to open it up to all the participants in rounds this evening. If anyone has any questions for Cindy, either based on the presentation that she made, or if you have any sort of questions that would be reasonable for a medical oncologist to answer based on your experiences at urgent care, the floor is yours.
Okay, so I see that Marissa asked if people get admitted for pain crisis all the time. So it's really hit or miss. I don't really understand sometimes how people come to us or versus. So I'll have a patient on active treatment be admitted to the hospitalist because that's who Emerge contacted. And then we'll have someone else who hasn't been on treatment for a year where the emergency physician will be adamant the medical oncology needs to take. So it's not kind of a black and white, this is who we take. You know, we have high intent, like the patients who are currently admitted under medical oncology for the most part are I'm going to say a lot of them are malignant bowel obstructions, biliary obstructions with infections from their drains, a lot of immunotherapy toxicities. And we actually don't have a dedicated ward. So our patients kind of get put anywhere. And so we're hoping in the new cancer center, June 2023, everybody, that's when we're supposed to be setting foot. We get the keys this June, but it'll take a year for us to get in. But anyways, we're hoping by then that we would love to have an urgent kind of drop-in capabilities, because right now we don't at the cancer center. Like we have zero space to see people if they're not booked into clinic. We just don't have the ability because every single desk, every exam room is taken up every moment of the working hours. So, you know, the hope would be that some of those patients would come through us because, you know, it might be the best thing. But again, we just don't have that capability right now. But a lot of our patients do get admitted for pain crisis. They go to hospitalists, they might go to the intensive palliative care unit. If they're actively getting radiation, they should be going to radiation because often it's radiation that's going to be managing their pain if it's like bone mets. Evan asked me, is there a typical timeline for progression of cord compression syndromes? No, because again, it will depend on, depends on the location, how quickly that tumor is progressing. So I don't think there's like a typical timeline. It'd be lovely if people just followed rules, but they don't.
So part of that, yeah, exactly, right. If everybody would just do the same thing. Part of that question is then essentially is if we recognize even early symptoms of what could be a cord compression syndrome, that's a now today kind of problem. We're not going to delay that at all. That's a today, call the neurosurgeon now.
Yeah, because they're more likely able to do something.
Yeah.
Because if it's something, if it's okay, we can see this patient, we don't need to do something today, but we can plan for it next week when we're not rushing and things are done. As with anything, if we can do it, not emergently, but either, it's not really electively, but in that more, in a timely manner, but not under pressure, outcomes will be better.
Sure.
So, oh, I see a baby. A sleepy baby. Oh, no. Any other questions? Is there any topic that you guys would be interested in from an oncologic perspective that I could help you with in the future?
What do you love to talk about?
Do you know what I love to talk about? Prognosis. What is prognosis? How do we determine prognosis? How do we, and I don't know if that's appropriate for urgent care, but I think a lot of times you guys are the first people that see patients and you're like, by the way, this looks like cancer. And I'm going to say it's not as frequent as it had been, but it used to be quite common where people would meet me for the first time. And the first doctor who spoke to them said, you probably have weeks to live. You should get your affairs in order. And
are you serious? People would say that?
I've had, you need to make peace with yourself as the opening statement. That chemo will kill you faster and maybe you shouldn't even go to the cancer center. I've had patients, and mind you, this is what the patients are telling me and I wasn't there. So that's their perception of what was told to them. I had a gentleman once sell his yacht and then he met me and he had a pancreatic neuroendocrine cancer and he lived for 8 years because he had an indolent malignancy. So I know it's just something that it's kind of like, how do we determine that? And when you don't have information, how do you have that conversation? Yeah. Because they're just dying to know. They just want to know something. And I think sometimes I'm comfortable talking about anything, but because I know. Now, I wouldn't be comfortable having a conversation with a pregnant woman about something related to their pregnancy because I haven't got a clue, but I think that first conversation has such an impact on the patient. It's unbelievable. I mean, I've had patients years later still bring up the first doctor who talked to them about their cancer. It just has such an impact on them. And sometimes it's just about how do you have that conversation? And again, everybody's different and there's no one right way to do it, but sometimes just the ways to kind of explain like what I know and what I don't know and why I can't give you more. And I don't know. Anyways, just something that if anybody's ever interested.
If you ever give that talk somewhere to us or somewhere else, I'd actually be interested. It's surprising how many times we are having to have that conversation with somebody with a newly diagnosed tumor. Yeah. And I would like to hear that talk one way or the other.
Well, and along those lines, the first time diagnosis of cancer in urgent care or in an emergency medicine or acute care setting is an interesting subject matter as well. Just sort of the, everything from the complicated referral channels to how you connect the dots, how sometimes our system is rather clumsy and laborious, and the easiest thing to do is just to admit the patient, even though they're not clinically unwell, and then have the right people lined up the next day, and also the psychological trauma that's associated with the first time diagnosis, and that news coming from a complete stranger who's time compressed and working in a high acuity environment. It's not great, and it's not great for anybody involved. So
as a bit of a follow-up to Garth, like the pathways, I find like if someone's got a pleural effusion but they're kind of stable and we're asked to organize a TAP like therapeutically, like I find it really complicated to do because like you'll call interventional and they'll basically send you an admission package to be like, oh, go in for this and then get their INR, and then the patient's already gone home, and I'm like, oh no. So I don't know if anyone else has like a better way.
Well, I even struggle getting a thoracentesis done. The patient hasn't already been seen by pulmonary. I have to go through the same hoops of, I have to fill out day medicine. I have to get the INR. They want to get the goals of care in there. They want my last note, and so it's there's not an easy way. I'm lucky being one of the lung cancer doctors that I'm, first name basis with all of our interventional pulmonologists, got paged about one of their patients. They just bronched and they wanted seen urgently. They just paged me and we talked about it, and this patient's going to get seen. But that's because I have a familiarity. But then when somebody comes in with like a biliary obstruction, which I never see, then I'm like scrambling and trying to figure out who I'm supposed to talk to. I know. I wish we had a lump and bump clinic, where somebody's got something that needs to have a needle put into it. And, there's some cities that have these lumps and bumps clinics where you guys would know exactly who. I mean, ATOP is fabulous. The Alberta Thoracic Oncology program. You've got anybody with a lump in there, you've got an abnormal chest x-ray. Those guys, the nurse practitioners in that clinic are phenomenal. They're seen quickly. They're thoroughly investigated. I can tell you when they come to me, it's so nice. They've got the workers' comp started for my mesothelioma patients. Like those sorts of clinics are phenomenal. And I wish we had more of them for different kind of lumps and bumps. But the Alberta Thoracic Oncology program, it's just phenomenal. We should have that for everything. We should have a liver mets clinic where there's just everything lined up and ready to go. You come in, you get your INR done, you get, we just don't have that right now, but it would be awesome. It would be great for patients. I know we have Dr. Jadasingh, who is a pathologist. He's a private pathologist. Our experience at the cancer center is it's great if it's benign. But as soon as it's something malignant, because he doesn't do all the additional tests and the molecular and all those things that determine, it actually can hamper our ability to move forward. So, because he's outside of Calgary Lab Services, he doesn't share the tissue. He doesn't. So it's a great if you think it's going to be benign, but if you think it's malignant, it's not a great way to go. But it would be great to have something like what Dr. Jadasingh has, because he biopsies and then looks at it himself. It's wonderful. Ooh, just got to chill. Okay. Anything else I can do for you? I can talk for days, so.
Okay, well, on behalf of all the urgent care doctors that attended here tonight, it looks like there was about 23, 24 of us representing a couple of different sites. Cindy, we really want to thank you for your time, especially volunteering your time in the evening when you probably have better things to do. But we really appreciate it. And like I said before, we really appreciate a friendly voice on the other end of a telephone when we're looking for advice. So from all of us, thanks very much. And we look forward to hearing from you again in the future.
Okay. I think Santa said, does interventional rad biopsy cover extended testing? I don't know what that question means. I'm sorry. So, can't hear you. No, you're still muted.
Hi there.
Hi.
What I'm wondering is if you get a rad to do a biopsy,
Yeah.
does that biopsy get further investigated? Unlike
Oh, yeah.
Dr. Jettison's?
Yeah, because Dr. Jettison does the biopsy himself and then does the tissue himself. Anything done within interventional goes to, the dedicated pathologist within AHS in our zone. And then it gets divvied up. So if it's coming from a breast, it'll probably go to a breast specific pathologist who will know exactly the right reflex testing to do and stuff. Yeah.
Thank you.
No worries. Okay. Well, good night, everybody.
Thanks so much, and take care. And
Okay.
thanks for everyone, all you urgent care doctors. Thanks for participating. And we look forward to our next urgent care rounds in the near future, I believe next month. Okay, take care.
Bye.
Thanks, Cindy. Thanks, Garth, for organizing.
Yeah, no worries. My pleasure.